Non-invasive approach for cavitated lesion. For GV Black, we have class 1 and class 2. What about non-invasive approach for cavitated lesion as in the modern concept? It started with the caries removal. Then you can perform minimal cavity design and restore with an adhesive restoration. Caries removal, minimal caries removal can use air abrasion, sono-abrasion, laser, chemomechanical methods, or ART. The air abrasion device and the cavity prepared with the pair. For the conventional method, we use a carbide or stainless steel pair. But nowadays, there is smart pair, which concentrated to remove only the carious dentine and not removing other sound tissues. The use of laser, prepared by laser. Mechanical caries removal means we have a chemical agent and use an instrument to remove. The most commonly used Caridax, Carisolve, and Papacarie. This is a Carisol, Caridax, Carisolve materials, which is red in color, added to the tooth structure. They soften the carious dentine, remove the final cavity without any carious lesion. Papacarie, applying solutions, get turbid, remove with a special instrument, reapply till the cavity is clear. Papers said that it is efficient method for caries removal but takes a longer time. You have to remove the caries lesion with the hand instrument, then to restore with aesthetic restoration, especially glass enamel. Nowadays, SDF silver diamide fluoride or the smart restoration is available to be applied to the caries lesion, either to use the silver diamide fluoride alone or with the ART. Minimal cavity design. Cavity design include small proximal box, tunnel preparation. It means to access the proximal decay, but you have to preserve the marginal ridge. It requires experience to reach the scariest lesion and to remove, and then to restore restoration. This is a tunnel preparation. I access from the distal fossa to remove all the carious lesion, keeping the marginal ridge, then to restore with adhesive restoration. Tunnel preparation. To perform a tunnel preparation, I should have a sufficient bulk of the marginal ridge, not less than 2.5 millimeter. If it is less than this, you have to perform a slot preparation. It looks like the proximal box, but without any definite rules. Slot preparation in D, lower D, upper E, you have to make two access to the carious lesion only to make a spot cavity. Spot cavities. This is summary. This is a slot. This is a proximal box with definite wall. This is the usual class 2 cavity preparation. As regard the class 3 cavity preparation, the same as the permanent teeth. You have to follow the outline, which is triangular in shape. The buccal and lingual wall should be parallel to the external surface. The gingival seat should be slightly inclined closely, and the depth of the cavity not more than 0.5 millimeter. If you have a closed contact, you can prepare a palatal. You can prepare take indirect approach for the carious lesion from the palatal surface. You can perform a dovetail that facilitates access to the carious lesion. These dovetails may be placed on the labial surface for the mandibular incisor or the palatal surface for the maxillary incisors. This is class 3. Class 3. Mattressing and application of aesthetic restoration. Class 4. which involve the incisal edge of the proximal surface of the anterior teeth. Sometimes the care is so extensive, and sometimes it is very superficial. Once it is very superficial, you can make disking, then apply fluoride. If moderate, have make an aesthetic restoration. If it is extensive, you have to perform an aesthetic crowns. Strap crown. Class 5 cavity preparation, the same as the permanent teeth, with a shallower depth and no need to bevel the margins. Class 5. In a summary, between the surgical model and the medical model for the cavity design, the same principles access and the old concept or in the surgical model, we're gaining access to the cavity and the prepare outline to the standard, prepare the cavity to the standard outline. While for the modern concept, we gain access to the caries lesion only, remove the caries only, and plan the final outline. The same for the outline for extension, no extension for prevention in the modern concept, but there is an extension of prevention for the surgical model or GV black concept. For the retention, the old concept or the conventional model depend on the macromechanical convergence of the wall, dovetails, undercut, axial groove, while in the modern concept, the micromechanical means of retention based on etching and bonding, beveling. In a summary, if you have a non-cavitated lesion, for the surgical approach, note differentiate between the non-cavitated or cavitated lesion, and you have to perform the sex classes identified. While non-cavitated lesion in the medical model can be treated with fluoride application, remineralizing agent, or resin infiltration. Cavitated lesion also in the modern concept, we can make a minimal cavity design. Preventive resin restoration, tunnel, slot, spot, ART, SDF, or SMART. For caries removal, usually we use the carbide or diamond pair. For medical model, use a smart pair, chemomechanical caries removal, laser, air abrasion. Restorative material in the medical model, all an adhesive restoration, which depend on the micromechanical means of retention. Just to tell about whole technique, nowadays available and too much evidence recommending its use. It is indicated mainly for proximal caries lesion, cavitated or non-cavitated, occlusal caries lesion. Can remove the decay, select a crown, fill with adhesive or any cement, then insert the crown, ask the patient to bite over. Restorative materials for pediatric dentistry. We have to wait between amalgam, composite, or other aesthetic restoration. In case of gross caries breakdown, restoration after pulp therapy, a full coverage like stainless steel crowns or veneered crowns is essential. Selection of the restorative materials depends on so many factors. Factors may be related to the child, like the child age, cooperation, physical and systemic condition, socioeconomic status, oral hygiene performance, and oral habit. If the child have like a proxies, it's better to use a full coverage rather than any restoration. Factor related to the tooth itself, the life expectancy of the tooth. The tooth is about to shed or still have a time. The form of the tooth and degree of calcification. Size and the condition of the remaining coronal portion. Vitality of the tooth. If the tooth is non-vital or heavy pulp therapy, you have to make a full coverage. Size of the lesion and its extension. Expansive lesion, it's better to use an aesthetic restoration, whether direct or indirect, to reinforce the remaining tooth structure. Here, with the use of each bond, then you have to build the tooth structure and finally restore to the normal shape function. Factors related to the oral cavity including the caries risk, moisture controls. All aesthetic restoration depends on the moisture control. If you can't make a proper moisture controls, it means you go into a failure of the material. The occlusion, factor related to the material itself, property, biocompatibility, adhesion, ease of manipulation, anti-carcinogenic property, and the cost. Summary of the question that may be in this chapter. What are the differences between class 2 cavity preparation between primary and permanent? What are the principles of the SISTA concept? Enumerate non-invasive approach for non-cavitated lesion. What are the non-invasive approach for cavitated lesion? Enumerate non-invasive methods for caries removal. What are the factors affecting the selection of your restorative materials? Which type of matrix is suitable for the primary teeth? By the end of this lecture, you can be able to answer all these questions. Thank you for your attention.